The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics.
Hello, everyone, and welcome back to the FlightBridgeED MDCAST. I'm your host. My name is Mike Lauria. I'm an emergency physician, critical care physician, and EMS physician who also works in the critical care transport environment. And today we have a special guest and an awesome topic to introduce. Everybody, I'd like to introduce you to Dr. Nick George. He is an amazing retrievalist, emergency physician, EMS physician as well. He actually started training and did medical school at the University of Maryland and then did residency and fellowships at UPMC in Pittsburgh. And of course, I met him along the way in the EMS training pathway. And then he went on to complete one of the coolest fellowships. Of course, I'm really biased on this one in the country, which is the University of Wisconsin's fellowship in retrieval and critical care transport medicine, and now has a super cool job working overseas, working down under. He's currently in Darwin, Australia, and is working as a full-time retrieval physician down there. So welcome, Nick, to the podcast. Thanks for being with us today.
Yeah, Mike, thank you very much. Thanks for having me. And yeah, it's good to be here from down under. It's awesome. Thank you.
What would you say before we get going? What would you say your favorite part about working full time in retrieval down there is?
Oh man, well, it's the optimal gig, right? You get to do every day from the air, and the outback in Darwin here is just the most stunning views you have ever seen. That coupled with saltwater crocodiles everywhere, it's an interesting time for sure.
Nice. Well, thanks for coming on the show today. Today we have a topic near and dear to my heart, working in the CTICU, which is aortic emergencies. I first heard Nick giving this talk at CCTMC a couple of years ago, almost, in Denver. And I remember walking by and just kind of like, Nick's presenting. I was like, aortic emergencies, okay. And then as he went along, the way he taught this was fantastic. His presentation, the slides were amazing. And he went over some very interesting stuff about aortic emergencies that totally caught my attention. So without further ado, we'll start talking about the old aorta.
Yeah, let's do it.
Nick, let's just start with like the basics. How do you think about and sort of your mental model for different aortic emergencies?
Yeah, thanks, Mike. So I've always thought that people really complicate this subject. The aorta is actually quite simple when you think about it, and I really, especially with that presentation, I endeavored to break it down in a way that, well, someone like an emergency physician like I could understand, but also just to try to really suss out what the treatment and the presentation of these, really, really high stress, high risk cases are. So the way I think about it is the aorta is really just a tube, and I talk about it in that it's as easy as 1, 2, 3, right? So the aorta is one tube. It has 3 layers, right? So you have the intima, which is the layer closest to the blood flowing, the media, and then the adventitia. So you have one tube, 3 layers, and only 2 things can really go wrong with this tube. And I like that, right? Because it breaks it down into something that is easy to conceptualize. So one of the things that can happen is it can tear, right? So you get a little defect in the intima and then you get tearing, or it can weaken. And sticking with my little 1, 2, 3 paradigm here, there are only 3 factors that can actually lead to that tearing or weakening. And those are what we call like the shear forces, right? You hear this all the time, and we'll talk more about that later. But that's the pressure, so your blood pressure, right? So all day, every day, your heart is exerting pressure against your aortic wall. The pulsatility, right? So that pressure changes, it goes up and down constantly. And then geometry. So those three factors lead to the two things that can go wrong. It can weaken and it can tear with this one tube, right? So I just take a very complicated subject in my brain and break it down into those very, very simple things. And I think if you break it down to that, that sets the groundwork for us to talk about the rest of aortic emergencies in a really simplified way.
That is a fantastic way, I think, to simplify that mental model. One tube, two major problems, three things that can do it. And one thing I wanted to touch on to clarify for our audience, when you say geometry, Nick, do you literally mean like the ovoid or circle shape? Do you mean like how it branches off, where it turns? What do you mean specifically by the geometry?
Yeah, exactly. So all of it, right? So the aorta has a lot of geometry. Your aortic arch is a pretty abrupt turn, and then there are all these offshoots, and all of those points are inherently going to be weaker due to the geometry, and that leads to specific issues. And when we get into the types of aortic emergencies, you'll see that actually this geometry does dictate some of how we even classify them.
Awesome. And then let's get into a little bit of what those emergencies are. But let's start out with some of the definitions, because I think defining some of these things, especially as our flight crews are going to hear them, they're going to read about them in the medical record, are actually pretty important. So let's start out with some of the fundamental definitions.
Yeah, exactly. And I think this is important, right? Because this happens all the time. You arrive to a hospital where a patient's been diagnosed with ostensibly an aortic dissection. You start reading the CT report, and then it says something like penetrating aortic ulcer. And it's like, well, what the heck is that, right? That's different than what I was told. So with definitions, right? So aortic emergencies it's a broad term that encompasses a number of different distinct pathologies. And it's super easy to get bogged down into the details, but if you keep it simple, right, as easy as 1, 2, 3, then you actually can conceptualize it in a pretty easy way, right? So I break it down into the tearing emergencies and then the emergencies where the wall gets weaker, right? So in the tearing emergencies, you have the first one, and I like to think that this is somewhat like a spectrum. That would be really nice if it was that easy. It's probably not. But just for simplicity's sake, the first one I talk about is penetrating aortic ulcer. So the idea is you get a small tear in the aortic intima. You get a little bit of blood that gets behind that small tear, and that is what we call a penetrating aortic ulcer, right? So that is the first type of sort of what could be thought of as that aortic dissection spectrum, but most likely is not actually truly like one leads to the next. The next one we hear a lot is intramural hematoma, right? So that's where blood gets in between the intima and the media, and it actually causes a larger defect, and the blood coagulates and you get this hematoma in your aortic wall. It's a little different than like periaortic hematomas and sort of that traumatic stuff, right? And I think it's important actually to remind the audience here that when we talk about aortic emergencies here, we're talking about medical aortic emergencies. So traumatic aortic emergencies are a whole different ball game. But yeah, so with medical aortic emergencies, you have the penetrating aortic ulcers, you have your intramural hematomas, and then we get into the aortic dissections, right? This is the one that everyone sort of kind of learns about already. And the dissections, we break down broadly into two types, right? You have your type A's and your type B's. And the easiest way to remember this is, like you brought up, Mike, right? The geometry, right? So that left subclavian artery, if the dissection involves any portion that is proximal or before the left subclavian, between that portion and your heart, it's automatically a type A. It doesn't matter where else in the aorta it is, that's a type A dissection. And then if it's confined to the area distal to the left subclavian, then it's a type B. That's just one of the classification systems. There are a few, but that's the one that That's the one that I find the easiest to sort of break them down into. Right. So that's the tearing emergencies. And then, of course, we have the emergencies where the wall gets weaker and sort of balloons out. Right. And now those are aneurysms. And the way we classify these really depends, again, right, to make it as simple as possible, it depends on the location and then how intact they are, or intactness, I like to say. So above the diaphragm, it's a thoracic aortic aneurysm. And if it's ruptured, it's a ruptured thoracic aortic aneurysm. Simple, right? And then below the diaphragm, you have your AAA, so your abdominal aortic aneurysm. And if it's ruptured, it's a ruptured AAA. Right. So just very basically, that's how I conceptualize the definitions. Right. I used to be really confused about, well, what's the difference between a penetrating aortic ulcer and a type B dissection, and what does that mean for treatment? And if you break it down into these two broad categories and then, simplify it into this classification scheme, I think it actually helps us with our mental model, especially when we're getting to these patients who are critically ill and we need to decide, as we'll talk about later, as to what our treatment modalities are going to be, right? Because there are sort of competing interests here.
Again, yeah, agreed. And especially, I think, in the transport setting, there are obviously some nuances to this in the surgical world, but this, I think, is a great way to boil it down to the clinically important pieces for us. And I think the things that our crews are most likely to hear about and or see in the chart, which leads me to the next point. I would say the vast majority of these in services across the United States, North America, et cetera, our crews are not necessarily diagnosing them, but they're getting transferred because the outside emergency department has identified one of these pathologies and needs to get them transferred. So it's interfacility transfer. But I still think it's actually really important for the crews to understand, for our teams to understand some of the important historical features for the patient and some of the important exam findings, because every now and then we find a STEMI that's actually a dissection or something else. And so would you mind going through some of the really important clinical historical features and the exam findings?
Yeah, Mike, absolutely. And, we're not quite there with our rotor wing CT, but I know you and I have been, that's our next entrepreneurial adventure.
I got a couple of friends that might get us a deal on a used Chinook, and we can stick a CT scanner in the back.
Exactly. So short of that, right, we're not going to be diagnosing for real a ton of these in the field. But yeah, exactly, right. It's so important for our crews to know how these present and the diagnostic scheme, because not only is it important for them to understand what's happening, what had happened in the hospital beforehand, but yeah, like you mentioned, right, this isn't something that is always just a foregone conclusion, right? So the clinical findings, right? So let's keep with our theme of simple here, right? So let's break it down into the history, the exam, and imaging. So history, this is always an interesting one for me with aortic emergencies. So with the dissection type pathologies, right? So your penetrating aortic ulcer, your intramural hematoma, and your type A and B dissection. These are classically what we know as like the chest pain plus diagnoses, right? So this is somebody who comes in with chest pain and they have some neurologic deficit, chest pain, and they have a pulseless left leg, right? That kind of thing. In that way, the majority of these are symptomatic, which is good, right? Because obviously this is a really scary diagnosis. It'd be kind of unfair if this was something that was asymptomatic most of the time. But it is important to know that up to 1/3 of aortic dissections actually don't have any pain, right? So it's important to keep this like super high on your differential. The other classic features, right? This is that sudden onset pain. They often describe it as tearing pain that runs to the back, right? And if you just think about it, right, this is the tearing of the layers of your aorta, a very innervated space, right? So it's going to be really, really painful. On the opposite side, you have the aortic aneurysms and the ruptured aortic aneurysms. Whereas dissections the majority of them are symptomatic. The majority of aortic aneurysms are asymptomatic, right? And so these are the folks who walk around for years. They have this aortic aneurysm that they don't even know about, right? That's why we do surveillance for this type of thing in certain patient populations, because the majority of people don't realize they have them. They can have some really vague features, right? That abdominal fullness, but it can also range from pretty much no symptoms at all to having severe abdominal pain. And again, this whole host of issues, like you can have, hemorrhagic shock and stuff like that. And so the history, while important to know, right, it's not super duper helpful in how we are going to conceptualize our diagnostic pathways, right? So if the history is not super helpful, right, a lot of it is somewhat vague. And like I said, a third of these patients with dissections are going to be asymptomatic. Well, what does the exam show? And unfortunately, it's not as helpful either. So classically, we talk in the literature or textbooks about a blood pressure differential in your extremities over 20 millimeters of mercury, right? But how often are we doing bilateral blood pressures, and just the machine is spitting out numbers that are just wildly varied? If every one of those patients had an aortic dissection, right, we'd be our CTICUs would be overwhelmed, right? We talk about pulse deficit between arms, but there are also a whole host of reasons that people could have pulse deficits between their two arms, right? Previous surgeries, if they have vascular disease otherwise. So there's not a whole lot that you can stake on this pulse deficit. Patients who have aortic dissections are often severely hypertensive. And then with your vital signs, right, this can be tricky, right? Because we often say, well, they're often quite hypertensive, but as we'll talk about in a little bit, right, some of the complications can actually cause you to be severely hypotensive. So just because someone doesn't have this raging high blood pressure doesn't mean that they don't have an aortic dissection, right? So it is a little bit tricky. And then with your aortic aneurysms, we often talk about on exam, you can feel this pulsatile mass, which actually, and I'm sure you felt it before, right? I've actually felt this, and it is pretty striking when you feel it, right? You're like, oh wow, that is what they were talking about in medical school when they said pulsatile mass. But again, right, it might not always be super easy to feel, especially in some of our patients who may be obese. It's going to be more difficult. This can also come with decreased lower extremity pulses. And then again, right, with this blood pressure, it can be one of two things. So it could be anything, right? It could be severely hypertensive, right? That's probably how they got the aortic aneurysm in the first place. And then they can also be severely hypotensive, right? If they're ruptured, if they've ruptured, right, they're going to be essentially in hemorrhagic shock. So it can be this whole spectrum. So that's all to say, right, that the history and exam are not super duper helpful, which is unfortunate, but still important to know. But that brings us to the imaging, right? So this is the way we really diagnose these. And I don't think this would be a talk with two emergency physicians if we didn't at least once. So we're going to do it once, and then we're going to move on. We didn't mention ultrasound, right? My trusty ultrasound. I feel like I got here to Australia. I work with a bunch of anesthesiologists, and we have ultrasounds on all the aircraft, and they've seen this dramatic spike in ultrasound usage and studies submitted, and that's because I'm there. So yes, so we can diagnose this on ultrasound, and I have before, right? Especially aortic aneurysms, ruptured aortic aneurysms. You'll see that large aorta. You could see possibly a positive FAST, but the gold standard, Mike, and this is important for our crews to know, because when they pick these patients up, and the patient comes with a diagnosis of X, right? You want to see how they diagnose that is CT angiography, right? Specifically, that arterial phase angiography to look at the entire aorta. That's the gold standard.
Yeah, I think that it is very helpful. I'm glad you mentioned the ultrasound thing, because I think as more and more programs are using it, if your clinical suspicion is high, if there's something weird in the story that's like, oh yeah, I'm having like this shooting pain, like here is tearing pain in my chest, but also like kind of down here going into my belly, or things that just like are not fitting together, and you have the capability to use it. Ultrasound is a very good way to at least I think begin to interrogate this, even in the field. The sensitivity and specificity, I'm actually not sure using ultrasound is likely, probably like many of the studies, dependent on the user and how experienced you are, and the device and your views, et cetera, et cetera. But I'm glad you mentioned that, because I do think we should keep that out there for our crews.
Yeah, and it's an exciting time, right? It's exciting that we have the ability for a lot of these crews to now start using ultrasound, and yeah, like you said, I think at some point, maybe in the future, we will be using it far more for diagnosing these. So stay tuned.
And just to piggyback on that, before we move on to talking about management, I think for all the crews out there, for those of you who are using ultrasound, as long as it doesn't delay time to definitive care or delay an evidence-based intervention, or you can do it in flight, I don't think there's anything ever really wrong with this, as long as it doesn't, hurt the patient or interfere with anything else. And to bring it up to like the receiving physician, it is probably, and I can't recommend, stopping the course of someone's transfer because you find something different, like they're going for a STEMI activation. You're like, I wonder if this might be an aneurysm. However, if you identify something that's odd, like I think this is an aneurysm, there's never any harm in advocating for the patient and showing it to the receiving physician or the sending physician, and being like, am I just, am I going crazy here? Or is this might lead us down a different pathway before we push a whole bunch of heparin or we do something else.
Yeah, absolutely.
Checking in with someone is, I think, always a very reasonable move.
Yeah, our crews should feel totally empowered to sort of use their clinical gestalt and their clinical findings to bring this stuff up. Because like I said, diagnosing aortic emergencies is super duper tough. And oftentimes we do miss it on the first go around. So the more eyes on the patient, the better. Yeah, exactly, Mike. I think that this is where our crews can add a lot of value.
I agree, my friend. Getting on to the management. So let's say take an archetypical case, right? You have a patient with an identified on CT scan Stanford A dissection that is going from a smaller ED at an outside hospital to the CT ICU at my institution or another institution. Let's talk about the medical management. And I remember in your talk, you had again, a very nice, simplified, beautiful sort of pathway that you walk through when you think about the medical management of these patients.
Yeah, man. Well, I think it's important to mention you said medical, right? And that's because that's what we're going to be able to offer in our critical care transport environment. But it is worth noting that oftentimes the definitive treatment for these illnesses, and why you mentioned we're transferring them to these tertiary centers, is because the definitive management is surgical. But I think you can't lose the forest for the trees. You need to get those patients there safely, and you need to get them there alive. And in order to do that, we really need to maximize our medical therapy. So yeah, I have again, a really easy, and maybe this is just my, I'm a little bit of a simple EM doc sometimes, right? I try to keep it as easy to understand as possible for myself, right? I like these like flow charts and this conceptualizing like this. So yeah, I'd love to share that model with everyone here. So if you think about medical treatment, we really just have one goal, whether it's an aortic dissection, whether it's an aortic aneurysm, whether it's ruptured, type A, type B. Our one goal is to keep the aorta intact, right? Because they're going to go in, they're going to do surgery, and we'd like to prevent any of the further complications of whatever is happening, right? Whether the aorta is propagating a dissection, whether it's rupturing into your retroperitoneum, right? So we want to keep it intact. But how do we do that? So remember back there when I said that there were really only 3 factors that caused the 2 issues with their aorta, right? So let's recap, right? Our 2 issues are the tearing issues and then the wall weakening. And we already know what falls under each of those. But there were 3 things that causes this. And that's what we often call like those shear forces, Mike, right? We always talk about this in, as if it's like this, this buzzword almost in medical school. It's like shear forces, boom, choice B, lock it in. Well, those 3 things, right? Pulsatility, right? So impulses, pressure, and geometry. Now, it's kind of nice because we can take those 3 things and we can actually break it down to just 2 of them because we can't control a patient's aortic geometry during critical care transport. So there's really only 2 things that we can address, and that's the pressure and the pulsatility. So with that in mind, right, so we want to keep the aorta intact. There's only 2 ways that we can really do that, or 2 things we can modify, the pressure and the pulsatility. Now we need to think about, okay, what is our model going to be when we take care of these patients? And I like to break it down at first. And I think this is a little bit different than how a lot of people do it. But for me, this helps because then you're not getting into the weeds of like what diagnostic category things fall into immediately. You can just really break it down into something that we know when we have a patient in front of us, right? And that's their blood pressure, right? So you take an aortic emergency and you just look at the patient, look at their vitals, and you can break them down into hypotensive aortic emergencies and hypertensive aortic emergencies. So let's start with the hypertensive ones, right? This is the simpler one. So we'll go through that first. So you have this hypertensive aortic emergency, regardless of whether it's a dissection or an aneurysm. And, thankfully, some folks who are really, really smart got together, both at the European Society for Cardiology and the American Heart Association, and they came out with some guidelines. So let's look at what those say. So the 2014 ESC guidelines say that the aim of medical therapy, right, and this is directly from the text, is to quote unquote reduce shear stress, right? So that's what we've been talking about, right? We want to keep the aorta intact essentially by reducing 1, blood pressure, and 2, cardiac contractility, right? So that's sort of what I mentioned before, right? The 2 things that we can actually affect. In this way, those guidelines mention that beta blockers are going to be your first line treatments and that some other agents may be useful. And the American Heart Association in 2022 sort of expanded on this and brought in some more refined language around it. So beta blockers are still first line in this guideline. And then they mention that to control blood pressure, if beta blockers don't work, you can start some intravenous vasodilators. And we'll get more into the specifics. And it's also really nice because the AHA guidelines here, and this is important, right, Mike? Because to mention here that obviously this is going to be institution dependent and protocol dependent. So obviously follow whatever your medical directors and the receiving physicians are recommending. But in general, they recommend, the American Heart Association, a systolic blood pressure less than 120 or your lowest blood pressure that you can have to maintain adequate end organ perfusion and a heart rate between 60 and 80. Okay, so that was a lot of words, right? I said this was going to be simple. So what does this all mean? Well, essentially what this breaks down to, Mike, is we want to control pulsatility. We want to control pressure. For pulsatility, we're going to give intravenous beta blockers. Oftentimes, that means we're going to be giving esmolol here in the United States. And then we want to control blood pressure. If that doesn't control blood pressure originally with esmolol, we're probably going to add a calcium channel blocker on like nicardipine or clofidipine, right? So that is the most simplified way of thinking about this. So let's back up, right? You have hypertensive aortic emergencies, regardless of whether it's a dissection or an aneurysm. Your anti-impulse control is going to be an IV beta blocker like esmolol. Your blood pressure control, if that's not already within range, is going to be a calcium channel blocker like nicardipine or clofidipine. And we're targeting here, generally, again, this is all institution dependent. Oftentimes I know vascular surgeons like a blood pressure way lower than 120 for ruptured aortic aneurysms, but we're going to target less than 120 or the lowest blood pressure to maintain your adequate end organ perfusion and that heart rate of 60 to 80. Right. So that's the hypertensive side. Let's now get into the little bit more of the complicated one, right? So this is the hypotensive patient. So a hypotensive aortic emergency actually requires us to put our thinking caps on a little bit more, which is awesome, right? That's why people listen to this podcast. That's why, people go into critical care transport, because they want to be really thinking about these. So if you have a hypotensive aortic emergency, you first have to decide whether it's a dissection or an aneurysm. And you can do that, obviously, in looking through the patient's records, talking with the referring physician, or even looking at their scans. But I'd like to point out to crews here that the way that this is documented sometimes is really confusing, right? A lot of times people will put in their notes that it's a dissecting aneurysm or something like that. And so deciding which one it is somewhat difficult. So this is where you just use your resources, talk to the physician, maybe call medical control, however that works in your system. But yeah, sometimes this is not as simple as just seeing that it's a type A, right? So if your patient's hypotensive, you need to decide if it's a dissection or an aneurysm. And really all we're looking at here is whether it's a type A dissection or a ruptured aneurysm, because aside from those two, the treatment is going to be the same. So if you have a type A dissection, and this is right, Mike, this is like the feared complication that, that I've seen before, and it always makes your stomach drop, right? This is where the type A dissection can actually dissect down into the pericardium and cause a pericardial effusion and then eventually tamponade, right? And this is super scary, because even if you drain that, that's, you haven't fixed the problem. The blood is still going to keep coming. But suffice it to say that if a person has a type A dissection and they're hypotensive, we need to be ruling out whether or not they have cardiac tamponade. And again, right, we can use ultrasound for this using your local protocols. This is something we need to consider. On the opposite end of the spectrum, if this is a ruptured aortic aneurysm, whether it's abdominal or thoracic, that person who is hypotensive with a ruptured aneurysm is going to present much like a trauma patient, right? This is something that we do all the time. And so it's actually kind of nice, right, to be able to put them into this box. It's like, okay, actually, this is an aortic emergency, but actually I'm just defaulting to my, trauma resuscitation that I normally do, right? So this is going to be blood, your sort of damage control stuff that, we all talk about these days. And if it's not either one of those, right, if it's a type B, if it's a penetrating aortic ulcer or intramural hematoma, if it's one of those other diagnoses and the patient is hypotensive, you're generally just going to use fluids, maybe some vasopressors, whatever your institution's protocols are. But essentially you want to keep them, right, that goal of keeping the aorta intact, but also keeping a perfusing blood pressure. So that's how I think about it, right? This, this super duper simple way of breaking down aortic emergencies.
I love it. Now, one of the things in your talk that really caught my eye, so we'll go over this stuff, because I think this is, as you like to point out, the fun stuff, the very interesting stuff before we wrap it up and bring it home. Was, Nick, we're all taught that impulse control is the most important thing. Get the beta blocker on board, get the esmolol going before you control their blood pressure. And then afterward, once you got their heart rate down, control their blood pressure. And for the life of me, up until you presented this, I was like, that's like a recommendation in every single book, in every single review article. There has to be very strong, very good evidence to suggest that like beta blocker is the drug of choice or drug type of choice, and esmolol is the agent of choice. Is that the case?
Yeah, well, as you mentioned, right, this is where it gets fun. And yeah, I thought the same thing too, right? We're always taught this, and you just imagine that when you're, gosh, this was like day one of medical school all the way up till the end of residency, right? It's like, again, right, those buzzwords like, impulse control. And yeah, it got me thinking because I worked at a flight program once where nicardipine was actually the first line agent for aortic emergencies like this. And I thought that was interesting. I'm like, man, that goes against a lot of the recommendations. I wonder if there's data here. And, maybe there's not great data for that. But the interesting thing is that there's really not great data for esmolol to begin with, right? So where did this all come from? Well, it's super interesting. In the 1970s, this group, they essentially created an aortic dissection model in dogs. So they gave dogs an aortic dissection, and they did two things, right? So they jacked their blood pressure up to, max is like mean arterial pressures of like 400 millimeters of mercury, right? So we're talking about real high blood pressures here. So with an aortic dissection, they brought their blood pressure up to 400 a map, and they noticed that the aortic dissection didn't propagate at all. And then they added some pulsatility in to that, and they noticed that the aortic dissection did propagate. And so immediately, that's kind of where this idea came from. And thus the anti-impulse reign was born. And that is where now everybody has developed this, thought that, well, you need to control the heart rate first because that study showed it, right? And then there were some other studies that maybe question this a little bit, but this sort of dogma, no pun intended, actually began. What they didn't really take into account then was that what was probably happening when they had their map up at 400 was that it was really just stenting the aorta open. That's why the propagation wasn't happening. And, that the, impulses actually did lead to the propagation, but who knows whether or not it's the impulses or the blood pressure that matter more, right? So this is where, and, this is way above anything that I understand, but this group did really like a biomechanical analysis. They looked at a bunch of equations and they tried to suss out whether or not it made more sense that blood pressure or heart rate was important in sort of the biomechanical tearing of the aortic wall, right? And actually, and again, right, calculus is about as far as I got. So this is super high level stuff, but they decided that, if you look at the equations, that it's probable that blood pressure actually matters a little bit more. And so taking all this together, right, it kind of makes you think like, well, do we actually need to be controlling the heart rate first? But then the question becomes, Mike, right, like, well, who cares, right? Does it actually matter, right? If you control heart rate or blood pressure first, like, is there a problem with this? And actually, it may be a little bit of an unpopular opinion, right? And again, to the listeners, this is sort of your somewhat evidence-free zone, and obviously just not ready for prime time yet, but just a fun thing to discuss, right? So with esmolol, right, it's a little bit of a tricky drug to titrate, right? There's not a whole lot of, people do different things with it. Do you bolus and then titrate? Do you just titrate? People have different thoughts. It's not really used a whole lot outside of aortic emergencies, which if you're doing a ton of aortic emergency transports, then obviously you get really slick with it. But other drugs like nicardipine, we're using for a whole host of other diagnoses, especially in critical care transport. And so people might be a little bit more familiar with those drugs. And then, just one thing that really sort of is pervasive here is that there's really no data that esmolol has better outcomes than, say nicardipine. And people are always worried about that sort of reflex tachycardia that you get with nicardipine, but is that actually the case, right? So all of these questions got us thinking. And so I was part of a group. We did a study where we looked at 1,196 aortic emergencies. And so this is a critical care transport agency that does rotor wing and ground transports. And we looked at over 1,000 aortic emergencies over like 2 decades. And our primary outcome, what we wanted to see was if patients reached that goal heart rate of 60 to 80 beats per minute, and whether they reached that goal blood pressure of 90 to 120. And that's systolic blood pressure. And we looked at a host of secondary outcomes too, right? And this is more of our like adverse outcomes, right? So we looked at hypotension, severe bradycardia, tachycardia, right? That like dreaded reflex tachycardia with nicardipine, and then the need for any vasopressors, inotropes, or if the patient went into cardiac arrest. And what we were looking at essentially is the use of esmolol versus the use of nicardipine for these patients. And the way we were able to do this is that protocols had evolved over time such that initially this agency used esmolol as their first line for these aortic emergency dissection type patients, right? And then they transitioned to nicardipine. So we were kind of able to use that as our comparators. And what we found was actually pretty interesting, right? So there was no significant difference in our analysis of achieving a heart rate or blood pressure goal between the two, right? So essentially, even though we say that esmolol is so much better at controlling your heart rate, it actually, in our analysis, was not any better than nicardipine at controlling heart rate. And if you look at the secondary outcomes, and the blood pressure was largely the same, right? It was actually near dead on, the same between the two groups. And then if you look at the adverse outcomes, there was more hypotension in the group that got esmolol. Now, this research has obviously had a number of limitations, and there's an ongoing larger study where we'll do some more savvy statistical analyses, right? So we didn't control for we were unable to control for drugs that people got beforehand, before we got there. So it's possible that a lot of those people had gotten beta blocks already. This is obviously one institution, but it's just interesting to think about that. This is like some foregone conclusion that we use this anti-impulse control up front. But with the potential that we could actually maybe hurt patients by causing them to be too hypotensive, or, again, esmolol is sometimes tricky to titrate. It can lead to some medication errors, right? This is potentially a future direction for critical care transport, actually starting with nicardipine, especially as it seems in this study, it doesn't actually cause all that much tachycardia. So this is, exciting stuff, Mike, right? There'll be more research on this, and hopefully, this is something that we can talk about again. So watch this space.
Absolutely. And I think so just to be clear, Nick brings up a fantastic point here, which is this is stuff going back. So if you happen to be a dog with a MAP of 400, you should probably hold off. You should probably get some impulse control on board, right? But otherwise, there's equipoise, I think, here to suggest that maybe we've been thinking about this since 1970, whatever, and haven't readdressed it, and it's time to readdress that. Please don't go running to your medical directors and tell them that I told you we should be doing nicardipine first, or Nick told you should be doing nicardipine first. This is very interesting. Maybe not quite time to change everything yet and flip it on its head, but we should be looking at this for sure, and stay tuned if there are other things coming in the future, more research that may actually be more practice changing. What I do think it tells you is absolutely, like, if their heart rate's reasonably well controlled, just get their blood pressure down, right?
Yeah.
If they've already gotten beta blockers and their heart rate's 78, really focus on getting their blood pressure down with something like nicardipine. The other thing I would say is often crews have come to me with questions about, my vascular surgeon, my cardiothoracic surgeon says we should be taking their blood pressure down to 100, or we should be taking their blood pressure down to whatever. And the guidelines do say as low as you can go with maintaining end organ perfusion. I actually think like the 120-ish range is pretty reasonable for a couple reasons. One, because if they're in my ICU, I can monitor their LFTs, I can carefully watch their urine output, I can do a whole bunch of other things to make sure that carefully lowering their blood pressure down as low as it'll go is not affecting those end organs. We can't really do that very well in transport.
Right.
So I think we got to be a little bit careful that we're a little bit more conservative, that we're not lowering it too much in transport. And the other thing is just remember that a lot of these people, number one risk factor in a lot of these cases, hypertension. So a lot of these people have lived with a blood pressure of, one in the 150s, 160s, 170s systolic, potentially even higher if they weren't well controlled before. So suddenly dropping them down to even lower than 120 is not without its challenges and dangers. That's why I generally tell people, let's just start out with 120 in the transport world. And then once they get to a place where we can control things and watch them closer, totally reasonable. And that's why I think a lot of our ICU nurses and colleagues are coming to be like, we should make them even lower. Good thought if you can monitor their end organ perfusion really, really well.
Yeah, it's a great
so that
point.
was Yeah, so that was awesome, Nick. That was a fantastic walk through all of the aspects of this, from thinking about the anatomy, the pathology, and your mental model for approaching the management. So remember, how does it go? Let me see if I got this right. One tube, right? Two major problems, tearing or weakening, and three things that can essentially cause it. We did go over the diagnosis, and it's pretty tricky, but luckily most of the time I feel like these are going to be transfers where it's already been diagnosed. The definitive management is surgical, but we're always going to be focusing on the medical management, which in the case of hypertensive patients is going to be getting their heart rate down and getting their blood pressure down one way or the other, using one drug or another, which may or may not, should or should not be potentially esmolol first. But if that's what you're using, go for it. And then, as Nick mentioned, for our hypotensive patients, we're basically going to be, and specifically with our hypotensive type A patients, remember that, yes, blood is absolutely something we should be giving them, but also look out for other causes like obstructive causes and tamponade that can definitely add to things. So anything else you want to leave our crews with, Nick? Any other key take-home points?
Yeah, just aortic emergencies can become really complicated pretty quickly. So, trying to stick to a very easy to understand framework, I think, is key, especially in these high stress environments. And stay tuned for our Chinook delivered CT to the field, where we're going to be diagnosing aortic emergencies in real time. It's the next stroke ambulance.
Walloping them with straight up nicardipine or clividipine.
Exactly.
Yep.
Exactly.
Nice.
Yeah. Thanks, Mike.
Thanks so much for your time, man. Ladies and gentlemen out there, you guys take care. Look forward to talking with you next time. And as always, fly safe. Bye-bye.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.